Today's module is on hip osteoarthritis. Commonly, this is called hip arthritis. This is a fairly common diagnosis among older patients. It's fairly rare in the younger patient unless they have, for example, significant trauma, such as like a hip fracture, or if they have a congenital condition, such as hip dysplasia. It's actually fairly straightforward to make this diagnosis, although I have found in my clinical practice the patients may go undiagnosed for months or even years at a time, often because other practitioners are not really doing a very basic physical exam maneuver of looking at hip rotation when they're assessing the patient's problems. We will talk about this more in the history and physical examination portion of this module, as well as touching on some treatments. Hip arthritis is very common in the older population, as I have mentioned. In the younger population, we usually need some sort of significant trauma, such as an intra-articular fracture of the hip or some sort of congenital condition like hip dysplasia. Typically, patients will come into your office and have pain more in the groin area, in the front. To a physician, the groin is actually the location of hip pain. Many patients think, well, their hip is back here. But in terms of anatomically, hip pain generally will radiate to the groin area. And that's an important distinction. So if a patient comes in, and I'm going to use my own body here, and says, "Doc, it's my hip," I don't think of the hip. I mean, very, very rarely this can be a hip problem. Usually I think of other structures, lumbosacral structures, SI joint, hip bursitis, but hip arthritis is in the front until proven otherwise. I would put the patient through lumbar range of motion nonetheless, generally not very reliable for picking this up, except sometimes, let's say it's the right hip in this patient's case. You know, don't move your lower body, I'm just going to turn you. Sometimes the hip arthritis is so severe that there's actually pain with just turning the upper body, because that effectively rotates the hip. The patient would lie down for the rest of the exam, and this is what really tends to clinch the diagnosis. They might have a little pain with the straight leg raise, but really where they're going to have pain and significant restriction is hip rotation. Typically they can only rotate that much. You can compare it to the other side, and they'll get exquisite pain in the groin area or the anterior thigh area. Another test that clinches this diagnosis, ruling out other diagnoses, would be the Stinchfield test. So when you're doing your motor exam, you have them hold the leg up, resist me, and they'll have either normal strength on the other side or at least no pain with that testing. The Stinchfield test, when you do it on the right side, is usually both painful and there's a lot of pain in the anterior thigh area and the groin area, which helps clinch the diagnosis. Finally, and most practitioners don't do this, but I find it useful, if you palpate in the anterior hip capsule area and compare the two sides, you'll find that the affected side is often more tender. I don't know why people don't do that, but it's probably not that necessary because you're kind of clinching the diagnosis with the rotation already. If you need to double check things when the patient's on their stomach, you can just rotate the hip and you'll find it quite restricted. Finally, you'll find that they're so restricted in their hip that if you look at hip extension, so you're trying to bring the hip up like this, they're quite a bit restricted on the affected side than the unaffected side. It's generally a very satisfying diagnosis to make because for some reasons patients don't get diagnosed quickly, and you at least have a plan for them. If it's advanced, at least these days, hip replacement is the treatment of choice. There's a question of whether stem cell treatment will help delay or replace hip replacement, but I think for now there are two things going on. Hip replacement is pretty good surgery. It's a ball and socket joint, remember, and as such it's pretty easy to, quote, replace. It's been around for 50, 60, 70 years. And again, if it's severe enough, patients often find that surgery is life-changing. So we sometimes try PRP in our clinic, but if it's advanced hip arthritis, I don't find it that helpful, and so I don't tend to do it. There are more conservative treatments, myofascial release, etc., but this is not the sort of thing you want to just belabor. Keep doing the same treatment if the patient's not getting better. Obviously, anti-inflammatories can help in that sort of thing.